Assalamu alaikum, doctors. I am Akil Haider, working as business manager in Genix Pharmaceuticals. On behalf of Genix Pharmaceutical Management, I welcome all of you. Let me give you a brief introduction of Genix Pharmaceuticals. Genix Pharma was founded in 2004. We have vision to help and provide top quality and affordable medicines for all. Genix is one of the fastest growing companies in Pakistan. Today, the topic of presentation is workshop on MMSC, presented by well-known legendary consultant neurologist Professor Dr. Arif Herekar. Dr. Arif Herekar is MD Neurology, Masters in Child Neurology from University of Rome. He is Chairman Headache Research Foundation of Pakistan, Chairman Department of Neurology, Baqai Medical University. He is also a visiting faculty in Dow University of Health Sciences. Dr. Saab is professionally very busy person, but always available for education. Dear doctors, if there is any question, please drop your question in question answer box. Question answer session will be after presentation. Now it's over to you, sir.
Okay. Bismillahirrahmanirrahim. My name is Professor Arif Herekar, and I've been the ex-chairman of the neurosciences at the Baqai Medical University. So the important thing is that today we will be talking about the mini mental state examination, which is called MMSE. Now, let me tell you, this is very, very important. MMSE is, why is MMSE so important? Because MMSE is used as a support tool for dementias, all types of dementia. So let's see what we have with us now. So the first thing is that what is dementia and Alzheimer's disease? So when we talk of dementia, we talk of a brain disorder, impaired intellectual functioning that interferes with daily activities of personal relationship. So when the activity of daily living is affected, जब इंसान normal चीजें नहीं कर पाता, that is when we say that he may have what we call dementia. See, giving labels to anyone who has memory loss is not good enough. So what we have is memory loss, language difficulty, decreased perception, and impaired reasoning. All these things put together will suggest the possibility of dementia. And one of the commonest causes of dementia is Alzheimer's disease. So coming to Alzheimer's disease, what is Alzheimer's disease? Now, when we talk of Alzheimer's disease, we talk of dementia. Now, dementia is not a normal part of aging process. The aging process becomes more rapidified, more expedited. It increases from the normal degenerative processes to an abnormal state, and that is called dementia. Unlike normal age-related memory changes, dementia gets worse over time. This is very important. It's a progressive disorder. All neurodegenerative disorders are progressive. That is very, very important. The other question is, what happens? What are the early symptoms of Alzheimer's disease? The most important is difficulty in remembering names. And of course, the recent events. The patient becomes apathetic or slow. And of course, he is depressed. Then as time goes on, his judgment is impaired. He becomes disoriented. He becomes confused. Confusion ho jata hai. And he has behavioral changes. Now, behavioral changes, ya mizaj mein change is very important part. Now, behavioral changes can be agitation, can be talking irrelevant things, can be restlessness and phobias, and many abnormal things. They form part of behavioral changes. And difficulty in speaking, swallowing, and walking. So all these things come as a later thing when a patient is suffering from what we call Alzheimer's disease. So we have different types of Alzheimer's disease. Of course, the progression is always there. It is a progressive neurological disorder. So there are three different categories of Alzheimer's disease. One is the mild form, the moderate form, and of course the end stage, which is called severe form, which is a severe form. So what happens in the mild stage? There's a short-term memory loss. Language problems are definitely coming on. And the mood swings. The patient is depressed, agitated, apathetic. So you have something like a bipolar thing. Then there are personality changes. It is normal personality changes. You don't see the same gentleman again. He's talking irrelevant. He used to be a bright old man. He used to deal with people. He used to deal with public. He's not doing that anymore. His judgment has deteriorated, is diminished. And if it gets into a moderate stage, the behavioral situation worsens. And of course, with that, the personality changes also worsen. So he is unable to learn, recall new things. So what actually happens when the patient's dementia gets worse? He used to do everything. He was a normal working guy. He used to work in the offices. He was teaching, he was a teacher, whatever he was doing. But now he's not able to recall or do something new. And his long-term memory is affected. He cannot recall or remember things. And he's wandering around. He does not know what he's doing. He's confused. He's agitated. He has aggression. He can become violent as well. And he starts talking irrelevantly. He repeats things which are irrelevant. And of course, he's confused. So at this point in time, he requires assistance. So his activity of daily living, which is called ADL, is affected. From the moderate type of dementia or Alzheimer's disease, the patient is getting worse. And it becomes more severe. His bladder and bowel controls are gone, which is called incontinence. And then comes the motor disturbances. His gait is affected. He cannot walk as he used to walk. I have seen patients with Alzheimer's disease 10 years into the Alzheimer's disease, but most of them will have some sort of a gait difficulty. And eventually, when it's getting worse, it gets so bad that his motor activity has fallen to almost zero and he becomes bedridden. He is unable to perform the activity of daily living. What is the activity of daily living? Having his own food, clothing himself, going to the toilet, all this is affected. So he is then placed in a long-term care, often which is needed. So how do we diagnose Alzheimer's disease or dementia for that state? Because dementia as a whole has several causes. And today we are going to focus ourselves on the commonest cause, and that is Alzheimer's disease. So since we do not have too much on us, we have something that can support the presence of dementia. And that is called the MMSC, or the Mini Mental State Examination, which is widely used, well validated. It is well validated. It's one of the most important tools, actually. It's one of the most important screening tools for evaluation of cognitive impairment. It is an 11-question measure, gives a complete survey of 5 areas of cognitive function. The orientation is tested, the registration is recorded or tested, the attention and calculation explode, the recall is tested, and of course, you also examine the language. So there are, like I said, 5 elements to the mini mental state examination. I've talked about orientation, we've talked about registration. The individual things that are here, I'm sure our hosts are recording it. I'm not going to go into these details because this is what you need to have. You need to have a printout of these so that you know what to ask when you're doing orientation. You need to know what you're asking when you need to check his registration and his attention and calculation. And then what are the problems in his recall, the 3 objects that he needs to know. And then language. And language is, of course, you need to repeat the following things like pencil and watch and all these things. So all this put together, 11 questions in 5 areas will give you a comprehensive result from the MMSC. We have one in Urdu. So items could be administered without additional equipment. You don't need, so this is a bedside examination. It's simple. That's why it's so important. I mean, everyone can do it. The general practitioners can do it. The young doctors can do it. The house officers can do it. The residents can do it. So it's a simple bedside tool to detect the cognitive decline, to detect the presence of dementia. And like you talk to him, tell him that there's a watch, a paper, a pencil, and then he has to repeat those things. So no interpretation of score needed, requires little critical thinking, and it's very quick to administer. That's why it's so important. Just 10 minutes. So the MMSC was not meant to be used for establishing a diagnosis of dementia. Now, this is a supportive thing. There's nothing that can actually confirm dementia or Alzheimer's disease or the cause of the dementia. But this is the most important single psychometric test which can support the presence of dementia. MMSC is a screening tool, and of course, like I've told you, it's not a diagnostic tool. So when do you do these tests? When do you do an MMSC? Why do you need to do it? The MMSC should be completed on all patients over age 65 and at any time whenever there is a concern about the cognitive decline. So when you look at a patient and you see his cognition is blunted, he cannot do what he used to do. He's not as apt, he's not as sharp, his behavior is also affected. So when you go into this and you see that there are signs that his cognition is declining, go in and do an MMSC. MMSC is far the more sensitive in detecting cognitive impairment than is the use of informal questioning or overall impression of patient's orientation. Some patients who appear cognitively intact turn out to have deficits on the cognitive. So what this is trying to say is that looking at a patient, you really cannot say. That is why the role of MMSC comes in, makes it very important. So when you do an MMSC, even people who apparently look normal can have deficits. Some patients who do not have deficits on cognitive tests turn out to be cognitively impaired. Education has been repeatedly shown to influence MMSE. So how to score MMSE? The appropriate descriptor of patient's level of consciousness is that these are number one, A is for alert, drowsy, stupor, and coma. So when you look at these, the level of consciousness is very, very important. The first, he remains alert, then he becomes drowsy, then there's stupor, and then there's coma. So these are the stages which make things worse. Now, continuing on to how to score the MMSC, each area tested has a designated point value with maximum possible score on the MMSC being 30 by 30. So the maximum score is 30 by 30. The score is recorded using a denominator of 30 unless the patient was unable to complete the test due to physical handicap. For example, if he's blind, he is physically handicapped, in which case the value of the questions not able to be completed is subtracted from 30 and the resulting number used as the denominator, the test score. Now, if the denominator of less than 30 is used, the nature of the physical handicap should be indicated on the MMSC form. So if the patient is physically handicapped, it must be mentioned. So how do you interpret the score actually? Widely accepted cutoff is 24 by 30 for MMSC. So if I start from, if you look at the MMSC, the normal score is 26 actually. 26 onwards is fairly normal. If someone is scoring between 21 and 26, then he has mild cognitive impairment. If he can score only 11 to 20, he is pretty moderate impairment. And if he scores under 10, it's quite severe. So how do you do it? When the purpose and value of MMSC is explained, well, it is readily accepted by most patients and family members. So it's a test where the compliance is very good. Therefore, it is extremely important to take time to explain the rationale for using this tool before commencing with the questions it contains. So orientation. Now, orientation is what is the date, what is the month, what is the year, and what is the day of the week, and what season is it. So these are very important questions which will tell you more about orientation. We will have these printouts given to them so that they can keep it with them. I'm not going to go into detail because it's going to be quite extensive, but you all need to have these MMSCs which will be provided by the company, and that will tell you about orientation, registration. And for registration, if you make the test of memory, then say ball, flag, tree, or any other word clearly and slowly about 1 second each. After you have said all the 3 words, ask him or her to repeat them. So this is registration. Is he registering what you're saying? And then we come to the attention and calculation. This is also a very important aspect of MMSC. Are the individual to begin with 100 and then count backwards by 7? Stop after 5 subtractions. Score the correct subtraction. So you have to subtract these things. So this is attention and calculation. This is quite a procedure. For example, 93, 86, 79, 72, 73. So what you do is, this is also called serial 7. You continue to subtract 7 from 100 and you go down. And as you go down, you will realize that this gentleman can do it. Are the individual to spell the word world backwards? Another thing, the score is the number of letters in the correct position. So then we come to the recall. The delayed verbal recall. Are the individual to recall the 3 words you previously asked him her to remember? So coming to the 3 words you previously asked him her to remember: ball, flag, and tree. So if he can recall these 3, then his recall is quite apt and good. So from recall, we go into the 5th and the last part of MMSC, which is the language. So naming, show the individual a wristwatch and ask him or her what it is. Repeat for pencil or anything else. Repetition, are the individual to repeat the following: no if, ands, or buts. Now, there are stages. 3rd stage command, give the individual a plain piece of paper and say, take the paper in your hand, fold it into half, and then put it on the floor. The takes, the fold, and puts, these things will tell you how good the gentleman is. Coming to reading, hold up a card, reading, close your eyes, so that the individual can see it clearly. Ask him or her to read it and do what it says. Score correctly only if the individual actually closes his or her eyes. Writing, give the individual a piece of paper and ask him or her to write a sentence. It is to be written spontaneously. It must contain a subject and verb and be sensible. So the other slightly more intricate thing is copying. Give the individual a piece of paper, ask him or her to copy a design, a simple design of 2 intersecting shapes. Now, one point is about it: for correctly copying the shapes, all angles on both the figures must be present. The figures must have one overlapping angle. So what are the strengths? The MMSC is effective as a screening instrument to separate patients with cognitive impairment from those without it, which is very, very important, which is the most important aspect of all dementias. And in addition, when used repeatedly, the instrument is able to measure changes in cognitive status that may benefit from intervention. So when you're intervening, when you're treating a patient with early or moderate dementia, you can continuously subject him to MMSC tests so that you know the progress or the improvement in the patient's condition. So it is something that can monitor it. Since its creation was in 1975, it has been validated and extensively used in clinical practice as well as research. So coming to MMSC Screen 2, 11th question, we will give you the handout so that you can expertise in orientation, registration, attention and calculation, recall, and of course, last but not the least, language and simple copying. So, of course, like every other thing, there are limitations to every psychometric test. The tool is not able to diagnose the case for changes in cognitive function and should not replace a complete clinical examination. Of course, like for example, someone comes to you and says that, sir, his or her MMSC was showed moderate or mild dementia. You have to match it up with the clinical outcome and the clinical presentation, because dementia is, of course, has many elements. You have to see it clinically, historically, and of course, that MMSC can be supported. In addition, the instrument relies heavily on verbal response and reading and writing. Of course, if a patient cannot talk, if his verbal quality is impaired, then he will not be able to do it. Of course, floor and ceiling effect, both of them are very important here. So what are the recommendations for the treatment of dementia? Now, Alzheimer's disease is a disease which, of course, has certain elements, like, for example, the role of acetylcholine and the role of glutamate. So what we do is we use cholinesterase inhibitors, ribostigmine, donepezil, galantamine, and tacrine at diagnosis. When you diagnose it, you start treating them with this. Of course, the other drugs with a different mode of action are the memantine alone or in combination with acetylcholinesterase inhibitor. This is in patients with moderate to severe Alzheimer's disease. You can have Parkinson's disease dementia. You can have, so ribostigmine is the only cholinesterase inhibitor approved by the PDD. Insufficient evidence for use of memantine. So the various presentations will be, you can always get from the company. The only thing I want to say is the indications. Indications are mild to moderately severe dementia associated with Alzheimer's disease and Alzheimer's disease associated with Parkinson's disease. So treatment can be started at a small dose and can be built up as and when and how it is tolerated. It may be increased to a minimum of 2 weeks of treatment to 3 mg, subsequently 4.5 up to a maximum of 6 mg. So what are the challenges of these cholinesterase drugs? Underdosing and poor treatment compliance are key issues. Of course, if there is lack of compliance, if the patient is not taking it, he won't be benefiting. So you have to monitor whether he is taking the requisite dose as per the doctor's orders. The answer is to improve therapeutic benefit. Number one, by optimizing dosing. Number two, monitoring treatment compliance. Number three, simplifying administration. And number four, minimizing side effects with smooth drug delivery, and of course, not a cure. So again, coming to the dosing, you can always get it with the, you have the list and everything. They will supply you with the dose required, and you have to monitor the patient. And like I've said, MMSC can also help show you how good things are going, whether the drugs are working, whether the patient is improving, and so on and so forth. Thank you very much. if you have any questions, I'm still here to tell you more about MMSC and the role it plays in Alzheimer's disease.
From the audience. How is the reliability of MMSC tests, sir? Or any supportive labs are required, or just we can rely on MMSC scores?
See, coming to MMSCs, if you look at the sensitivity scale, it is almost 60-70% reliable. But the negative thing is also important. It is just not, I must emphasize that this is a very good tool. It is one of the best psychometric tests for dementia. But of course, the reliability is 60-70%. But together with the presence of whatever the scoring is, you must have a clinical and historical element, so that all the things put together will help you in diagnosing, just not MMSC alone.
Sir, another question, I think you have already explained it, but question is there, that's why I will ask you. What are the limitations of MMSC, sir?
Yeah, I've already told you that if the patient cannot speak, if he has a verbal deficit, you cannot do it. The other thing is that MMSCs are, of course, you have to know how to administer the MMSC. So whenever someone administers an MMSC, he must know the 5 main factors and the appropriate 11 questions. And then the results are fairly good, because you know why it is so important? Because there's no confirmatory test ever for Alzheimer's disease. See, the other tests that we do are the imaging. All you can see in Alzheimer's disease is some cortical atrophy, mostly focused on the temporal and parietal areas. So in that way, MMSC is important, both for supportive evidence and to monitor the progress of the patient.
Sir, another question is from a doctor. He want to know is there any difference between the treatment of donepezil and rivastigmine, sir, which is more beneficial?
Well, they both have the same mode of action. They both have the same mode of action. They let me tell you, the important thing is that for memory and recall and behavior, the neurotransmitter is acetylcholine. So what both of these drugs do, now acetylcholine levels are controlled by cholinesterase enzyme. Both of these levels go through inhibition of cholinesterase, and they have almost similar mode of action.
Sir, in last, I would like to thank you for your very nice presentation, sir. It was very nice.
You're most welcome.
And thank you so much for your valuable time you have given us.
I only hope that all the youngsters have understood and registered whatever I have said. Thank you.
Sure, sir. Sure. Thanks a lot, sir. Thanks a lot for your time.